Hi everyone, Dr. Steve Rasner back here. If you're watching me, which most of you don't, and I look really tired, it is because I just woke up from a nap. I'm only saying that because I can see what I look like, and it's not so pretty. But you don't tune in every week to look at me. You tune in, I hope, for some ideas that'll make your journey a little smoother in this challenging profession that you and I chose called dentistry. For the last two podcasts, I've been talking about what I think is the most important time that you spend each day if you have a new patient. Obviously, it's important because when people accept your treatment consistently, you get to walk in on Monday to productive days. Here's what I used to say in my lectures 15 years ago. I just really, you have no idea how much energy and time that your podcast host spent before he ever did one presentation. Because I had a 4 or 5 month leeway between the first time I was ever invited and until it actually happened. I had like 4 to 5 months. And I would sit down in my basement at the time and prepare, and over-prepare. And into each subject that I wanted to discuss, whether it was staff, whether it was your clinical requirements, in my opinion, to maximize your career, or whether it was case presentation, I would intro it with this very dramatic couple paragraphs. And what I used to say was this: how you spend your days, whether they're peaceful or frenetic, whether they are fulfilling or not challenging, whether they're productive or another wasted day, has everything to do with patients saying yes. And then I would say to the staff, how you spend your days, how many patients you treat each day, whether you get lunch, how able your boss is to contribute to a pension plan, if you're having fun or maybe miserable, has everything to do with patients saying yes. Yeah, and I believe 15, 20 years later, absolutely that it's that critical. So that's why I've spent so much time during the series in the last 3.5 years on patients saying yes. So I thought about it before I got on today. And there's not even any way I can finish it even today. I have to break up the podcast into smaller elements, or I don't think you'll get it. And what I mean by that is sometimes it's easier than other times as to how you and what you should say. Let's back up for a minute. This patient came into your office with the history usually that I outlined in my last podcast. In other words, and it's just a fact, and we have to be aware of that fact because it's relevant to what this patient may say to you. Okay? So let's think about it for a minute. In most instances, many of our colleagues treat the patient according to the maximum allowed by their insurance. I mean, it's just a silly proposition. I don't know how to... I know. I get it. I know. It's intimidating to look at a person in a chair that you just met a few minutes ago and end up recommending things to them that makes them do something that maybe they've never had to do. And that would be financially invest in their oral health beyond an insurance allowance that their employer set up. Come on, guys. I mean, if you're listening to me by now, you must believe and must understand that that can't be your guiding light to your dental treatment. How could it be? What do you do, for example, with a patient that has a clear terminal dentition? They have 20 plus teeth that need to be removed. There aren't even a question. Everybody in dentistry would agree that these 20 teeth should be removed. That exceeds their maximum. That's an easy one for you, right? So I'm simply saying to you, break that down further. I'm not here today on this podcast or last week telling you to talk patients into veneering their top 12 and lower teeth or full coverage crown all their teeth so that they'll look better. That isn't at all where I'm coming from. You don't even have to think like that. I really do believe, from doing this for so many years, that if you just bought in and maybe go back to my first 4 or 5 podcasts from 3.5 years ago and looked at case presentation, if you just bought in to understanding that it is better for the patient for you to look at 5 arenas of their mouth before recommending to them and telling them that, right? I've gone over how to do that. And then doing it. If you did that, you wouldn't have time to take courses on how to get wrinkles out of their face with Botox because you'd be too busy doing something called dentistry. I'm not kidding. It's almost laughable to me. And it's apps that you have to find and invent other things to do. Now, I know some of you are going to be offended when I say what I just said. And you're probably better at it. Some of you are better at injectables than maybe even a plastic surgeon's office. I've never had the time to even explore that significantly because I believe I have to begin with what I just said to you. And I think that's how you should begin. And if you did that type of exam, this I'm 100% positive of. On every patient that comes to you, unless they're a child or unless they're 18 with a just exquisite oral health mouth, if you did that, you would be, everything in your world of dentistry would change. And if you believed in your office enough, hold on, and you believed in the concept of getting paid up front so that they will complete their care, that's the main, by far, objective for a patient to pay you up front, so that you don't find yourself in a vulnerable position 18 months after you met them, that you started treatment because you had a policy that allowed them to pay a very small portion. They don't come back. Now you and the patient loses. If one of you anywhere in the world is listening right now, and you think my motive for having them pay me up front is any other thing, then you're not getting me, you're not getting the podcast, you don't understand. It's never been that. And if you go into a new case presentation with the hopes that the patient will spend a lot of money on something that you're recommending, if that even enters your mind, then you're in the wrong mental state to present recommended treatment to a patient. I 100% believe in what I just said to you, and I hope you buy into it, and I hope that you, if you don't understand it or anything else, that you would write to me and reach out to me, which very few of you do. Some of you do. And I know, it's fine because it's hard for me to get back to even the ones that do. I just want to, know that you're listening. So I'm going back to this today, and I've given it more thought. So let's now get back to what I'm trying to start to be very specific with you, in that the hardest thing for me to translate to another dentist, because I believe it's hard for all of us, is figuring out exactly what we should recommend on a new patient exam. with a patient that has a multitude. Now, sometimes, obviously, it's quite easy because they don't have a multitude of needs. Correct? We all get that. But I come across patients, and maybe it's because I have a heavy sedation practice. So that sedation practice attracts patients who haven't been to a dentist in a while, so they have a multitude of needs. Where do you go with that? Okay, well, the first thing you have to do is turn on your ears and listen to why they're here. And a simple question. It's in the very beginning of your conversation with this patient. So what brought you to me today? Well, what's on your mind? When was the last time did you go to the dentist? And you're going to get all kinds of answers. If they tell you, well, 5 years ago, I don't know. They're good things. They're good things because that patient should be open to the fact that there could be a number of issues. Obviously, it's much harder. If you have somebody who has a broken dental relationship recently, who has gone to the dentist regularly, and they have a multitude of issues, or if that patient went to the doctor you hear me talk about all the time, good old Joe, who patched everything. And remember, I understand good old Joe. I just don't respect it. I'm sorry, I don't. Because you and I chose a profession where much of the pathology is asymptomatic. So it is incumbent. It is more our responsibility, not less, to really let patients know what's going on in their mouth. Nobody calls us up, guys, and says, listen, I haven't been in 3 years, or I've been going regularly, but I'm pretty convinced that a lot of my restorations are leaking. My gums are, it's probably cased 2 or 3 perio, as you dentists call it. I know I like my occlusion equilibrium. Nobody talks like that. Even smart, socioeconomically high up the ladder patients walk around with mouths full of pathology all the time. It's behind the lips and they just can't see it. I'm just not certain, but I know that it's surprising to me often. The patient, doctors come in, lawyers come in, people of means, and not only do they have ugly dentistry in their mouth, they have pathology. So the first thing, as I mentioned before, and this is kind of a little, so you ask them so you can get a sense what they think their mouth is about, because that will help you. Okay? Because if they don't think there's anything wrong, I just have this one broken tooth, I'm sure. I mean, I floss, I brush my, did you love this one? I brush my teeth every day. Oh, that's impressive. Okay, thank you. It's like, I put oil on my car once. Okay, I am listening because it's giving me an image of what this patient's temperature is in regard to their oral health. Okay, then I'm asking myself, somewhere in that equation, by the way, this is, what am I going to recommend? Is their personality. Only by that I mean, if it's a thinker or a relator, it is less likely that I will recommend day one. Not too impactful. And you know what the personalities are. Just review them. Google them. There's 4 of them. Driver, socializer, relator, and thinker. It doesn't dictate my treatment. It may dictate when I recommend. Sometimes. Depends how much of that personality they are. For example, drivers would like you to recommend day one. They want to know what they have to do, and they'll do it. Socializer will accept anything you tell them, even if it's wrong, and they'll be happy with it. They're forgiving. They're wonderful people. They just don't usually have any money. So, what are the have-tos, and what are your lines in the sand? I am starting on purpose with the simplest approach, because it does get heavier as we get into more complex types of oral health care that we provide. So I'm starting with the easy stuff. What do they think is going on? That you're going to ask in all situations. Do you have any pain? Is any pain going on in your mouth, Mr. Smith? Okay. What are the have-tos and what are the lines in the sand? So, for example, have you ever had somebody in your office, the new patient coordinator or the treatment coordinator, come to you, and when you did your diagnoses and treatment recommendations, you said quad scalenes, and they came back to you and says, "Can they just have a regular prophy?" I mean, it's insulting. No, when that rarely happens with me, like the way my coordinator would put that is she would say, "Do they have to have quad scales?" That's how they'll put it. And my response is kind of like, "No, I just exaggerated that like everything else I'm going to tell you. They didn't need quad scales. I just wanted to jack up the fee." Come on, man. If we're not honest about everything, then we're not. So perio is big for me, and it should be big for you. I will tell you that most patients don't have healthy gums. In fact, I am surprised. And by the way, I make a big deal about it to that patient when they do have healthy gums. It says a lot to me, and there's no way you can project who's going to have it and who's not. Most do not. If you think of the legends of dentistry in your community, whether you're over there listening to me on the other side of the world or in the United States, like somebody that has a great name in dentistry, think about this for a minute. I will almost guarantee you every time they had the same philosophy I have in regard to the health of their periodontium. And that's part of the reason their work looks so good for so long. Do you get me? Poor periodontal health will wreck the best of work, no matter how impeccable your margins were and anything else you have going there. So it's not an arena of the mouth that you can compromise in. So again, I'm going over, when I'm looking at a new patient, they're what I call have-tos, and I don't hesitate for a second. I would say most patients that come to me, I don't know a percentage, need something beyond a typical adult prophy. Do I treatment plan FGGs or subepithelial connective tissue grafts for all insufficient attached gingiva? Absolutely not. It depends on a multitude of things. So I don't do, that is not a have to for me. It kind of depends on what's going on in the area and what am I treating that area? Okay? And look, if you're not comfortable, you should certainly work with your periodontist. You have to ask yourself all the time, would the patient outcome be better if I work this case with my specialist, no matter what it is? Do you know that I've been in practice 42 years? And over those 42 years, I've employed, like many of you, a number of endodontists so I could keep the business in-house. It's absolutely true, I did it. But I never was able to just love the endo that was done. It was good, but it wasn't, in my opinion, as good as the endodontist that's in my particular area of town, two of them. And I don't know, I had an epiphany years ago that I really think a lot of my restorative work is very, very exceptional. And if I have an average endo underneath an exceptional gold inlay or crown or whatever it is, it's no longer exceptional, is it? So I just gave it up. I send anything complicated. Now, maybe you're amazing at it. Are you amazing at it? I'm talking endo in this case. Certainly, if I think a patient is better with ortho, and I can't really fix the crowding with restorative, it's not even a thought. It's really the same premise I gave you last week and early in this podcast when I said to you, just go in and have that neon sign in your head telling you, be a great clinician. And whatever that recommendation is, present it in a way, A, that the patient never even dreams that you're thinking of money. I'm saying it to you because it's true. You know, there's going to be somebody listening somewhere that's having a really bad month of whatever it is, May. And maybe you have somebody coming in that only has X amount of thousands of dollars to spend. Maybe they qualified for one of the Care Credit Lending Club, Green Sky. They don't really have the, whatever the right fee is, $12,000 to do the case the way it should be done. So then you start to compromise so that it'll fit the budget they have. And the question becomes, is that compromise a compromise of oral health or anything else? And I understand that somebody might end up with a partial denture versus fixed. That's fine as long as the patient understands that. That's not what I'm talking about. But I am talking about, I don't know, you doing crowns at a more inexpensive lab or something to save the cost on what the case really should have been. Okay, so back to where lines in the sand is what I'm talking about. So perio is not something I'm going to negotiate with. What about periapical lesions? Most of the time I'm going to insist, even if they're asymptomatic, that they treat them. Sometimes a periapical lesion has been dormant, as you know, for years. It's there, but it's not active. And that's really a clinical decision that you have to make personally. There's been times I've left. I've had a patient sign off on that particular aspect. How about retained roots? Right? So these are lines in the sand. No, sometimes I actually keep retained roots as I call it banking for bone. In the event that the patient may have an implant in that retained root. Most of the time, obviously, we're removing them. But let's say it's a premolar or molar. They can't afford to take it out and put an implant in. So I will bank it and I will tell them that. Missing teeth is huge. One of the mistakes a lot of my young colleagues make is feeling the need to replace a first molar that's been out for 15 years and maybe the only tooth missing. That would be a mistake in terms of trust and confidence at a first visit, unless that patient asked you to do that. I recently had a patient come in that did ask. Okay? This is how I would implore you to run this part of your practice. I had done implants on him 20 years ago on his left two molars, and now he wanted to treat the right. And when I did that, when I went to examine him, he had insufficient bone, and it was going to require a ramus graft and a lot of time investment by this patient. And I made that vividly clear. And he had the money. And when I put it out there with him, I said, this is not going to be, I need you to know this, like the last one I did for you 20 years ago, because you had the bone at that time, and growing bone's a different thing. And he needed a significant graft. I mean, he was absolutely concave in the area that I needed. And it may have taken more than one graft, quite honestly. So that's my approach to you. Missing teeth, a lot of times, my patients do not have the replacement of non-smile line missing teeth in the first phase of treatment unless there's an occlusal big problem to the amount of teeth they have missing. So understand what I'm going over with you right now. I'm going over what I call the have-tos. So what do they have to have done that you just can't get around? And we've talked right now about Periapical lesions, retained roots, missing teeth. Missing teeth is not a deal breaker all the time with me. What do you do when that patient comes in and when they take out their partials, the teeth missing are missing in such a way that there's no occlusion, correct? In other words, maybe they're missing without prosthetics in their mouth. Their vertical is tremendously collapsed. That's a big case. That's that case I told you about last week where you see that very early on. You're going through these 5 arenas of their mouth, but you see I have major occlusal issues here. That's never going to be a small case. That is a huge case, and I'll stop the exam, sit them up, and say, before I get too far into this, I know things already that I want to discuss, so I need to get a feel from you of where you want to end up. I'm not going to rebuild a patient's case on a collapsed vertical. And that is a common problem that we run into, right? So what about this common one? Really large restorations, open contacts, or overhangs. So again, you're looking at this patient for the first time and you're looking at their perio. There may be a periapical lesion. There's a retained root. There's already some missing teeth. And there's some MOD, BL, MOUSC amalgams. It depends. I mean, if it's an abutment for something I need, like a partial, it's absolutely getting crowned. Asymptomatic or not. If it's just sitting there in a quadrant with all the other teeth, and it's just ugly as all get out, but I can't find decay on the radiograph or clinically, it's just ugly, it's not essential if the patient doesn't want it to be. So these are my kind of guidelines. Open contacts, I try to explain I ask the patient, do you have a food trap up here? That I go into why a food trap is bad. Overhangs, I'm replacing restorations with overhangs. And why we're on this subject right now about restorations, I have to say to you that I truly believe, and it's something I learned in the 90s, that indirect restorations are far superior to anything you can do direct. So either whether you mill it in your office or you use a laboratory and you do diligence to what you're supposed to do, clean preparations and clean tissue, and the lab knows this, by the way, and you get back a crown from a lab, it's going to be better than what you could have done clinically in the mouth. Guess what? That costs more. Guess what? It looks better in 10 years than whatever you did. So you're starting to get a flavor right now. And I know what a lot of you are still thinking, and that's why I'm just not done. You're thinking, am I going to recommend too much? Will this patient be intimidated? And that's why all that other talk I gave you over the last 2 podcasts, this is the 3rd one, on that critical 5 minutes. That's why you have to come in sincere and embrace this philosophy of comprehensive care for the betterment of their mouth. Now, not everybody wants that, man. And you don't have to kick them out unless they violate a deal breaker. Like, I'm not going to do a crown, and I'm not going to think it's okay for you to do full coverage in a sea of inflammation. I had a patient come in this week, and I'm talking the 77. New patient, right? He came in, I want you to hear this, and I'm going to stop at this. He came in because he broke the posterior abutment of a 3-unit bridge on his lower left side. So the molar was the abutment, the first molar was sapponic, and the second premolar was the other abutment for the 3-unit bridge. And the molar was blown out with decay and shot. This is a guy that had good osseous support, decent perio. But beyond that, when I did this is a good example for you. When I did this exam, he had slight recurrent caries on 2 other teeth full coverage crowns that had endo. And guess what? The endos were really short. Wouldn't it be great if poor endodontics was symptomatic, so I didn't have to explain this to him? It's not even business in my office, even if that was my goal. I just would not restore those teeth. I want you to picture 2 endos, I'm talking 6 millimeters short. There was no symptoms there. There was no areas periapically on either. These are 2 different teeth. And my treatment plan included retreating the endos along with core and crown buildups. And that is how I think you should approach it. Now, we have not addressed, the other thing is, are you setting yourself up for failure? I think a lot of the younger dentists might be setting themselves up because you're actually under-recommending. I see that over and over again. So I hope this is resonating with you guys because it's such the part of your career that either sets you up for healthy patient care, interesting days, a great reputation, or otherwise. And it's taking a lot because I purposely am going after today the easier decisions for you to make. I mean, I'm making these decisions that we're covering right now in 30 minutes often. And so will you as time goes on. You know why it'll happen to you? Because you'll experience failure and it'll bother you. You'll have a crown blow up. What do you tell that patient? That you didn't have the endodontics redone? That you recrowned it because it had just recurrent decay. But you knew the endo was bad. There was no periapical lesion, no symptoms, but you knew the endo was insufficient. What do you tell them when it blows up 2 years later? Even if you got away with it and they didn't blame you, does it feel right? No, it doesn't feel right. So, periodontal disease is probably one of the most neglected diagnoses that dentists make. I know it's not unique to me, and I'm not saying, I am certain in my 40 years I have misdiagnosed, I have missed things, no doubt to me. I've done stuff that I couldn't figure out how that came out of my desk. But it's been a long time because I am vigilant. Because, you know why, guys? Just like you. Just like the reason you're listening to me today, right now. I care. So I've studied under others, and I care. A Lionhearted dentist does care. I think I'm already past having to convince you of that. And next week, we're going to talk more about, well, how far do we go? Lots of these cases are massive that come into my office, and I'm not even, I should just put it out there, this is going to stun you, I'm not even a giant advocate of all on anything. Fixed work on implants on a patient that lost their teeth. I know the statistics are impressive on these patients, but I'm not a big advocate of anything that'll make it harder for them to maintain a prosthesis we made when they couldn't maintain their natural teeth. Have a great week. Keep learning. Reach out to me and say hi. I'd appreciate it. It's Dr. Rasner, Dr. Rasner at AOL.com. I know it's laughable that it's AOL.com, but that's what it is. Thanks for listening. See you next week on The Lionhearted.